communication was not so watertight. So, delusion is something that you believe which is false and you continue to do. Obsession is something that you know this is false, but still you continue to do. A delusional person doesn't know that what he believes is true or false, he just believes true. But obsessional person, he knows that what I feel or what I think is not true, but still he performs action on that. So that's the difference. He said that this is monomania. It's a chronic disease of the brain without any fever on those days. And then there are a lot of theories related to the intellect, emotions and will. Then again, moral, he defined it as a delire emotive. He also worked on the other psychosis, which affective psychosis and personality disorder are part of. He said it's an intense emotional state which is repetitive in nature. And he said that there is something that's wrong with the person that even he cannot control, and he keeps checking things repeatedly. He keeps washing hands repeatedly, things like that. Janet, again from the psychoanalytical mindset, this person said that it's a la automatisme psychologique, something which is happening on the automatic mode. He says the nervosis et id fixes. Again, les obsessions et la psychasthenie. So, some kind of psychiatric problem, right, which deals with the first time in the history obsession came into the picture from the Janet. He said even before the Sigmund Freud, he said there are 3 stages. One individual does it, but he doesn't know. That is, Freud defined it as unconscious. And then something that he know little bit, which is kind of subconscious, and the other thing is conscious. Who is he? Any idea? He is Sigmund Freud. Okay, he is still called as father of psychoanalysis, and he developed principles of talking therapy, which was called as psychoanalysis. He was a neurologist by himself, but he developed a lot of interest in how certain behaviors are not explained by the brain. So, neurologist turning into a psychoanalyst. So, he started leaving his neurology practice, and he started focusing on sitting on the chair and listening to what the patient is telling, and patient lies on the couch, his famous technique. He said what other scientists have said, he also said it's obsessional neurosis. And if you go to the Vienna, if you get an opportunity, you can go to the Sigmund Freud museum, and it's very beautiful. Everything that was associated with Sigmund Freud, even his bag, his spectacles, everything is kept there, and it's very beautiful. So, coming back and talking about encephalitic lethargica. Lethargica is something like a tiredness. Encephalitis is the infection of the brain. So, this was again the primitive conceptualization. From there, people have moved to the obsessive compulsive disorder, which has no fever, no encephalitis, no slowness. So, ICD and DSM, we had a class last time. What is the difference between ICD and DSM? What is DSM? What is ICD? Anyone? We spoke about it last time. Yes? Anyone? No idea. These are diagnostic manuals. One is followed only in United States of America. Which one is that? Very good. And the other one is ICD, which is followed all across the world. Now they are in sync with each other. Earlier there were a lot of differences. So latest version is DSM 5 and ICD 11. Okay, you should know this, right? When we are studying psychiatry, this comes very closer, how much you are aware about the classificatory system. So from obsessional neurosis of Sigmund Freud to the OCD, now we, till the ICD 10, it was like predominantly obsession, predominantly compulsion, mixed obsessions and compulsions, and now it is OCD. So coming back to your first learning objective, what is an obsession? And you should know this. Obsession is a repetitive and persistent thought, okay, that a person identifies it as irrational and he cannot get rid of it. The thought coming to your mind, and that's repetitive. It's not just for a day or two, it is persistent throughout weeks to months. And then you cannot get rid of this thought. There's something called as ego dystonicity. What is ego dystonicity? I cannot get rid of this. Loss of control. Okay? I want to control this. I'm getting a thought. The door is not locked. But I know that I have locked the door. I am 100% sure. But this thought is telling me, you have not locked the door. This is senseless thought, because I know that I have locked my door. So this thought is persistent, repetitive in nature. And can I control this thought? No, I am not able to control this thought. If I can control it, very good, I don't have any problem. But if I am not able to control this thought, how do I get rid of this thought? To undo this thought, I will have to do the action. And I will go and check my door. I will go and check my door. I come back. Again I get the same thought, repetitive, persistent, repetitive. The thought is not making any sense. I know that. I have locked the door. Senseless or irrational. Ego dystonic, not able to control it. And how to get relief? Just by doing the act. As soon as I go, I check the door, it's locked. As soon as I turn my back, you have not locked the door. That's my thought. So this is the problem, and this can happen to any content. So what is an obsession? Obsession is persistent, recurrent, ego dystonic, irrational, intrusive and anxiety provoking thought. It may be thought, it may be idea, it may be image. An image coming to your mind. You don't want that image. It's a very dirty image, but you cannot get rid of it. And you know that this is not what I want, but I cannot help it out. It's beyond my control. So that's becoming obsessional in nature, right? It's not something that conventionally we say, I'm obsessed with this girl. It's not about that. I'm obsessed with this boy because we like them. So that's not an obsession. Obsession is something I don't like this thought, but it's still coming to my mind. That's an obsession. And how to get rid of it? How can I get rid of my thought? By doing some action. Okay, because this thought is creating a lot of anxiety. If I don't check the door, the thieves will barge in. How do I get rid of it? It's distressing, it's provoking anxiety, it's impairing my functioning. So I go and check the door. I do it multiple times, maybe 5 times, 10 times, 20 times, there is no count. This is the action that's taken to reduce the anxiety produced by the obsessions is called as speak aloud. The action that is performed to reduce the anxiety produced by obsession is called as compulsion. So is that clear? What is an obsession? Loud. Why you are doing like this? Speak aloud. Once again, what is an obsession? Okay. It could be thought, it could be idea, it could be urge, it could be image, it could be fear. So obsession has a lot of forms. These are called as the forms of obsession. What is the content of obsession? We will come to that. Like I said, the doubt was the content of obsession and checking was the content of compulsion. And compulsion is repetitive behaviors or mental acts in response to obsession to relieve anxiety. Very simple. Any confusion? We missed one term here. I did not explain. Which one is that? Very good. Intrusive. What does that mean? Intrusive is something that comes suddenly. You don't want that. That intrudes in your mind. So if you are studying, you don't want something, but then that is coming to your mind. Intrusive. Suppose you are idle and it is coming to your mind, you don't mind it, right? But if you are going to sleep and that time if the thought is coming, check the door, check the gas knob. Probably it's open and it will blast. So when you are performing something intrudes into your activity and disturbs you. That's intrusive. So if something fulfills this definition, probably person has obsession in its evaluation. Now theories There are behavioral theories like this. There are cognitive theories, as I said, neurobiology, the biological theories, genetic theories, evolutionary theories, like some people say this is a protective mechanism, suddenly it develops into the pathology, because I want to check my pockets while I walk on the road, because I need to ensure that my keys are not lost, my wallet is safe. That's a protective mechanism, evolutionary. But then if that turns into pathology, if I keep checking my pockets 100 times, then that becomes a OCD. Cognitive behavioral model. Madam will talk about it in little detail. There are multiple theories. I want you to focus on Maurer's two-stage theory. This is most commonly talked about behavioral principles. Also, in the therapy, we can explain this to the patient, how these responses are associated with your behavior, why you are afraid of certain things, and why certain things are performed repeatedly. And the person has to have some insight. What I am doing is not actually me, it's a part of my brain, or it's a pathology that's doing, so we can deal with that. So person removes his guilt from him. I am not having any problem, it's just a little bit, we can deal with that. Otherwise person have guilt, why I am thinking like this, why I am doing like this, I am bad person. So a neutral stimulus becomes associated with fear, which is called as classical conditioning. Okay? So if you don't have fear, the fear develops that there is a COVID, for example. So COVID, मुझे भी COVID हो जाएगा, I'll get a COVID infection. My friends are getting COVID infection. At the same time, you are going around and opening the doors, going inside the bathroom, etc. And then you feel that if I touch the doorknobs, I'll get COVID. This is the neutral stimulus getting associated with the infection. That's the what we call as a fear stimulus. So this is called as a classical conditioning. Later on, what happens over the period of time is that the operant conditioning happens, the doorknobs directly associate with the fear, right? Initially it is not associated, later it is associated. So every time you check the doorknob, you try to touch the doorknob, you get a thought that you might get a COVID. So this is called as the conditioning principle. And then to avoid that, you will maybe do like this and open the door, or you will ask somebody else to open the door, and you start developing a lot of impairment in your daily activities. Or if you touch, first thing you will avoid, but if you touch, you will have to go for the restroom to wash your hand. Okay? So how many times will you do that? So we in the therapy, we deal with the conditioning. We might ask them to dissociate these two thoughts and actions altogether. There are other double reinforcement theory, schedule induced theory, punish avoidance theory, sensitization over habituation. Something that is sensitized will extinct. The principle says कि आपके साथ में कोई दो stimulus associated हो गए हैं, over a period of time थोड़े दिन रहेंगे. Fear of knob associated with the infection acquiring will stay for a few days, but otherwise it will extinct 1-2-4 महीने बाद. But if that doesn't happen, it happens to be habituation or sensitization, generalization. Conditioning के principles है, एक होता है extinction, fear चली जाना, एक होता है generalization. इसमें fear generalize हो जाती है. डोर नॉब के साथ खिड़की में भी आ जाएगी, पर्दे में भी आ जाएगी, चादर में भी आ जाएगी. You will wear gloves and things like that. So difficult. Coming back to the Freudian and Neo-Freudian area, where they did not know most behavioral principles, and they focus on the human psyche as id, ego, superego. These are the three psychological mechanisms. So they say it's Oedipal conflict, anal fixation. Basically, a child develops. Child has a lot of anxiety during day 1 to day 2, day 3, as and when he develops. And he said the child is fixated at certain stage. That's why he puts everything in mouth. Some oral fixation. He takes a lot of time, in urinating, defecating, because he gets the pleasure as a child, while retention of the stools and then release of the stool, anal fixation. So what Freud conceptualized, there are psychosocial stages of development, and the anal fixation has been linked with the doing and not doing things, which is called as obsession compulsion nowadays. So he conceptualized it like, I need to do it, but I don't know, I don't want to do it. I need to do it, but I don't want to do it. So that's somewhere. And the defense mechanisms will help you to get out of this dilemma. This is called as, I mean, you can go back in the library and read about Kaplan and Sadok. There is a chapter on how OCD is explained from the defense mechanism. Defense mechanisms of isolation, undoing, reaction formation are commonly talked about in context of OCD. Then similar theories, object relation theory, if they say that OCD results from early disruption in relationship of primary caregivers. बच्चे के माँ बाप बिछड़ गए हैं, बच्चे को स्ट्रेस हो गया है, अटैचमेंट लॉस हो गया है. To manage the internal distress, it's little bit complicated. You need not go into details of that. Then come back to the more towards biology. In biology, you have anatomy, physiology, and biochemistry. So in physiology, attention, processing, error detection, and the what we call as a mismatch negativity. So here, obsession and compulsion arise due to overactive error detection in the brain. Okay, many things we do in the day-to-day life, we do not remember them. For example, if you go out of this hall, go to the canteen, maybe, I don't know, canteen or hostel, wherever, or in the OPD, and suddenly you realize that, how did I come? I don't know. We do not keep a track of that. For example, do the otherwise, you keep a track of everything for these events. Hyper focusing. Okay, you give the lot of attention to each and every detail. How I stepped out of this hall, how I stepped from hall to the lift, how I pressed the lift button. Hyper focusing. So that's the attention. And if there is overactive error detection. So more your brain focuses on certain tasks, it's the inherent tendency of the brain to detect errors. And then you will say, did I press the button or not? Did I put right foot first out of the hall or left foot first out of the hall? So these are the theories which explains the hyper focusing will lead to the hyper erroring, the increased error. And then similarly, intrinsic comparator defect talks about the cortical apparatus, the subcortical apparatus, that's basal ganglia and substantia nigra, and then communication between these two. Attentional dysfunction, again similar thoughts, similar things. Limbic basal ganglia, this is a biology. A circuit called as a cortico-stratothalamo-cortical loop. We call this as CSTC, cortex, stratum, thalamus, cortex. So there is a functional network. ऐसा कोई structure नहीं बना हुआ है, structures different है, but how do they communicate with each other is called as a cortico-stratothalamo-cortical. So this loop maintains the OCD behavior. Which are the forms of obsession? Yes, madam. नहीं, slide में नहीं है कुछ, आपको बताना पड़ेगा. Yes, you, orange. What are the forms of obsession? We spoke about it. From this side, okay, there is no hyper focus, there is no focus. Any idea, any thought, any image, any fear, any urge, any impulse. These could be forms of obsessions. So it could be sudden image coming to your mind. It could be an idea coming to your mind. Why sky is blue? Irrational, repetitive. If it is distressing you, it becomes obsession. It could be a thought. It could be sexual thought. It could be contamination thought. It could be infectious thought. Anything. So these are the forms of obsessions. What is the content of obsession? Should differentiate between two. Forms clear. What could be the content? A contamination. My hands might get contaminated. What could be the compulsion? Cleaning of the hands. We just spoke about that example, doorknob, COVID, क्लासिकल कंडीशनिंग, कोविड गया फिर भी डोर नॉब और इन्फेक्शन एसोसिएटेड है, ऑपरेंट कंडीशनिंग. Symmetry, what is symmetry? Many people have this system in the life. I want these books on the left side of my room, this on the right side of the room. These chappals on the left side of the entrance, these slippers on the right side of the entrance. Anything maybe. Symmetry. This table should be like this. Books, Harrison in the center, Love and Belly in the left, and the things that we read for the exam on the right. Right? This is called as symmetry obsessions. If you spend more time in that, it becomes a problem. You keep doing orderliness. Doubt, it's called as obsessional doubt or pathological doubt, and the behavior that is performed to get rid of this doubt is called as checking behavior or counting behavior. Clear? Anything is going in? No? You are not able to understand? Yes or no? Yes, you are not able to understand. You are not able to understand? No, you are not able to understand. Okay, so we move ahead. We have less time. Aggressive and harm obsession. किचन में छुरी देख लिया, किचन में नाइफ देख लिया. People feel that I might stab this knife to myself or somebody else. ठीक है? This is obsessional thought. We call this as aggressive or harm obsessions. Person knows कि मैं ऐसा नहीं करूँगा यार, मेरे वाइफ, मेरे बच्चे, मैं क्यों करूँगा ऐसे, बट ये थॉट मेरे को क्यों आ रहा है. When he steps into the kitchen, he sees a knife, he feels that, I might kill myself or I might kill my wife and things like that. So he keep asking wife again, did I harm you? Did I touch knife? Wife say, what happened to you? No. So his behavior keeps increasing. He asks children, children, did I beat you? Did I hit you? Children say, no, Papa, nothing's wrong. They keep checking every time. Okay, and they stop going to kitchen after a while. Because that's the best way to avoid the aggressive harm obsessions. So avoidance behavior is quite related with the OCD. And then we need to treat them, because there are a lot of problems associated with that. In the workplace also they start asking people, did I beat you? So people say, stop talking to this man, he's talking nonsense every time. He asks whether he has stabbed you, whether he asks whether he has beaten you, he asks whether he has shoot you. But the person is distressed, he is not able to handle his own emotions. He knows that some thoughts are coming to my mind. He should come to the psychiatrist or psychologist to get help. There are some religious obsessions. Om Namah Shivaya 101 times I have to perform while getting out of the door. While reaching the office, I have to do these rituals. I have to step back 5 times. I have to step front 5 times. I'm not joking. This happens. This is an actual OCD problem, and people do this thing. A lot of rituals. You will. There is amazing kind of rituals that you will come across. We have a lot of examples. And then people chant mantras to relieve sexual obsessions. People feel that their relatives, they have sexual feelings for them, for their own relatives. And they feel that, no, I don't want these thoughts, but they come to me. How to get rid of this? Okay? So, really, the sexual obsessions. People go to the temples and they feel God is being punished by me. I am slapping slippers and shoes to the God, idol, or whatever it is. So, they don't want this thought. You understand the intensity of obsessional thought? It could be very devastating for that person, the person who is religious. And look at the contrast. The person who is shy will get the knife related thought. Person who is religious will get the blasphemous or sexual obsessions related thoughts. So it's that way, and the person gets lot of this. They perform lot of just right phenomena is sensory OCD, where people wherever they go they start touching things. So once they touch, they feel okay, it's just right. Okay. Over a period of time, it becomes a compulsive behavior. So like this. then tapping, the touching, tapping, and then the complex mechanism sets up. Now, some people, most of the people will have insight, they are aware about their problem. Many people may not be aware about their problem. They feel that, no, I may maintain a lot of cleanliness in the house, but they don't know that this is a part of OCD. Majority knows, we call that as insight. So, insight could be good or fair or poor, or it could be absent or delusional according to the latest classification. Some compulsions can take more than 1 hour per day, right, and it could be yielding and non-yielding. Yielding is something that you have to do as a part of motor phenomena to relieve the obsession. Some things, right, like checking the door, checking the key, checking the gas knob, okay, washing your hands. So, these are the compulsions where, you know, we call this as overt yielding compulsion. Some compulsions may not be yielding, maybe these are the non-yielding compulsions, reassurance seeking, the like, did I beat you, right. So, it relieves his anxiety because I have not beaten, but I am getting a thought that I have beaten you. So, he is asking, it is a reassurance seeking. And then avoidance, people avoid going to the place. And the proxy, proxy is something that I will not touch the doorknob, somebody else will touch the doorknob to open it. I think a lot of people are relating this to themselves. Okay. The newer approach that I focus on in the patients is obsessive compulsive disorder and the other disorder that we spoke about. What is OCRD? Here it is coming for the first time, and you should be able to enumerate what is OCRD. I will ask madam you again. So, what is OCRD is very important for all of you. It could be obsessive compulsive disorder, it could be body dysmorphic disorder. Body dysmorphic disorder is a person looks at him in the mirror and feels that there is a flaw in the body, flaw in the part of body, flaw in the face, right side, left side, ears upside, downside, there is no symmetry, etc., etc., but similar to the obsessive compulsive. And then they keep checking repeatedly, they keep doing makeup multiple times, they keep cutting hairs in a different way. If they feel this side is small, they will keep large hair this side and this side the small hairs according to their perception. But then that becomes a problem based on, you know, insight, whether they know it, they don't know it. Sometimes impulsivity is also related with the OCRD. So, how impulsively these thoughts come, how impulsively these images come. On the other hand, how impulsively person performs the action. Okay. And we call this as sometimes body focused repetitive behaviors. This might also include childhood problems like nail biting. Children bite their nails, children do thumb sucking. Right now it is not there, but it might come. It is a repetitive pattern of behavior in children. So, body focused repetitive. Overt, covert. Overt is something that is visible, covert is something that is not visible. So, if I am chanting mantra or doing some things repeatedly in my mind, that is a covert compulsion. To reduce the anxiety, I am doing it some multiple times every day, every night, and it is becoming problematic. So, that is the covert compulsion. Overt is something that you can watch, he is doing something repeatedly. Counting you cannot watch, chanting you cannot watch. Reinforcement or reward pattern. So, again some things, it is a double reinforcement theory which we skipped. So, person feels relieved by doing the act, obsession is gone. Okay. That at the same time pleasure is also associated, right, and that positive and negative reinforcement together play a role in a long habituated OCD patients. Body dysmorphic disorder is another disorder which is in OCRD. Hoarding, what is hoarding? Just a random thought, what is hoarding? Yeah, you are right, your actions are right. What were your actions? Yeah, so collecting, that is what I got it from. So, you collect many things which are useless, you do it repeatedly, persistently, you know that I do not want to throw it, I mean I do not want to collect it, but I do not want to throw it as well. So, your room becomes a museum. It could be selected items, it could be other items. Okay, so there are a few other disorders. Excoriation, skin picking, कुछ बच्चे से निकालते रहते हैं. Persistent, repetitive, I don't want to do it, but I still peel my skin. It could be anywhere, in the fingers also. It could be from this area, it could be from any area, right? People have also included trichotillomania, hairs nikalna. I don't want to do it, but I cannot control it. And then they develop bald patches when they come back to us. Hey, doctor, please do. They go to dermatology to repair those bald patches, but dermatologists send them back to us. This is not our job. You have some other problem. Then olfactory reference syndrome is something that people feel that they are smelling foul persistently, repeatedly. In the public places, they ask other people, or they wear mask, or while talking, they talk like this. They talk like this. They feel they are emitting foul smell, and the other person, if they cough or laugh, they feel that they are having referential ideas. Like it's because I am smelling foul, they are coughing. Somebody coughed here just now. But that's the olfactory. Hypochondriasis. Now recently included, hypochondriasis is something that, you know what is hypochondriasis, right? It's illness anxiety disorder. I have HIV, so that's something that fear. Person goes to the clinician multiple times, does investigation, and he doesn't turn out to be HIV, and he wants HIV. Basically, he doesn't want HIV, right? So you understand the dilemma. Whether he wants the HIV diagnosis or he doesn't want HIV. He doesn't want, then he should keep quiet, right? One doctor tells him these tests are fine, but still persistent, repetitive, ego dystonic, intrusive, irrational thought. So that is why now hypochondriasis is kept in obsessive compulsive related disorder. This is the CSTC circuit. If somebody asks you at the end of the seminar or afterwards in your life, which circuit is implicated in the obsessive compulsive and related disorder, you should know cortico, striato, thalamo, cortical circuit. Clear? It's also called as the CSTC circuit. Striatum is nothing but all basal ganglia structure, striatum, caudate, putamen. There is indirect pathway and there is a direct pathway. You will study when you come to the PG psychiatry. And the same circuit is implicated in Parkinson's disease. So Parkinson is again repetitive hand tremors, and OCD is repetitive thought tremors. So treatment of severe OCD is nothing but deep brain stimulation, which is a treatment for Parkinson's disease. In the end, that's not performed routinely. I am just trying to show you the similarity between the neurobiology of obsessive compulsive related disorder. Fine, we will not spend time here, and then anyway, this Mudita will take care of this therapy. Compulsive behaviors could be conscious, unconscious, and then I have already told you some things are yielding, some things you cannot see because they are mental. You should know they are very much common. Everything comes down to the 1 to 2% when we talk about the prevalence. OCRD behaviors like obsessive compulsive disorder is 1 to 1.2%. The 12-month prevalence is basically focused on. The body dysmorphic is 1.7 to 2%. Hoarding disorder is little higher. Again, little higher is excoriation, skin picking disorder. The age group which is common in children is tics. You know what is tics? Tics. Yeah, एक मूवी आई थी बीच में, रानी मुखर्जी. Which one? Yes, Hitchcock, right? So there they have shown the tics, right? And the syndrome that is associated with tics is a Tourette syndrome. Okay, so that is again a repetitive motor behavior. In childhood you will say that OCD is often associated with the tic disorder and Tourette syndrome. There is a triad of this. Okay, many of the times. So that's why tic disorder is also included here. It happens in adolescence and early adulthood. As when person grows, it relieves automatically. So some things remains, that person adapts to it. Again, skin picking is not seen in adults, it's again in the children group. So olfactory reference syndrome could start in the adolescence. There's one more disorder which starts in the childhood, probably trichotillomania. Okay, rest are more or less starting after 20 years of age, right, 18 to 20. So, but these trichotillomania, skin excoriation and tick, these starts in the childhood. Clear? Body dysmorphic disorder, we have touched upon it. So, person feels that something is flawed, looks in the mirror, repeated mirror checking, excessive grooming, if tanning, sunlight and excessive exposure, things that they feel are appropriate. Reassurance seeking from the other people. Do you feel that my ear is small and this is large and things like that. So, comparing with the previous photographs, this I was very good. Both the eyes were symmetrical, now left eye is becoming little on the left side and right little on the right side. So, you can never have the limits to that, but it is a distress to that person, and we treat. They generally go to plastic surgeon directly. They will not come to psychiatry, and the plastic surgeon feels if he wants money he will do. But he is ethical. If he is doing ethical practice and he feels no, this is not something that I should do. This patient probably needs psychiatrist help, so he will refer to the psychiatry. Now this is hoarding, okay, collecting a newspaper, collecting books and things like that. And the most important thing is there is anxiety when mother comes and throws these things away. The mother can diagnose this. Okay. The child says, no mommy, you do anything but not this. Okay. So, that is the level of anxiety. We have few patients of trichotillomania from adolescent to the 85 age. So, earlier picture was the old lady which came to us with the hair picking at the age of 85. Okay. And this is the young adolescent, 18 years. Just before the exam, she felt, no, I have to wear cap for exam now. Okay, because I have no hairs. She lost, there are multiple bald patches in fact in the front. They are helpless, and as I said that this could lead to serious consequences also. Sometimes it is not just plucking the hairs repeatedly, persistently, ego dystonically, intrusively, irrationally. It is beyond that. It is feeling the hairs also. You can feel the hairs. That is a sensory phenomenon associated with OCD. It is trichotillomania, and sometimes they test it, right. Sometimes they grind the teeth with it. They feel it, and sometimes they eat it. Once they eat it regularly, what will happen? Trichobazor or phytobazor are the things which are non-edible items collected into the stomach, leads to the bowel obstruction. So, young girl with the bald patches coming to the emergency with abdominal pain. What could be the diagnosis? Okay. This is how USMLE people make the questions. So, this can lead to the musculoskeletal injury, blepharitis, dental damage, swallowing of hairs, trichophagia, bowel obstruction and perforations. This is a skin excoriation, again the same thing. Other OC spectrum could be substance induced, medication induced and things like this. One entity you should know which will come into pediatrics is PANDAS. It is a pediatric autoimmune neuropsychiatric disorders associated with one bacteria which is A beta hemolytic streptococci. So, people having this PANDAS have repetitive behaviors, OCD. So, those with the history of arthritis in the childhood, those with the history of sore throat in the childhood have some association with the repetitive behaviors. Tourette syndrome, read about it. How to differentiate it from anxiety? Okay. Anxiety is more about the worries. Worries could be for the normal things, not for the why sky is blue. Patient cannot get anxious because why sky is blue. That is OCD. But patient can get anxious, why this, it is raining, I have to go out. So, when anxiety we are talking about, it is a real life situation most of the time. When we are talking about obsession, there is worry, distress, anxiety, everything, but this is about irrational thing, right? Clear? How to differentiate between depression? Depression can also have some themes which look irrational, but the thoughts that depressed persons say are mostly egocentric. whereas in OCD it is ego dystonic. Hypochondriasis we just spoke. Obsessive compulsive personality disorder भी रहता है एक. What is that? It's the anancastic personality. Person is too rigid about his behavior. बाहर जाएगा तो सूट बूट में जाएगा, घर में आएगा तो डाइनिंग टेबल पे खाना चाहिए. He wants everything set in his life. We also used to call this a type A personality, which has a lot of OCPD traits. It's not the disorder, but it's the personality disorder. Right? A person wants everything in line, and then maybe he don't face problems, but the people who are working with him will face a problem. So they will bring him to the psychiatrist. इसका कुछ करो. Okay, so that is he wants his life in his way is a egocentric, whereas the OCD person says, I don't want these thoughts, I don't want symmetry in my life, but his thoughts are coming. It's ego dystonic. Okay, so there is a difference between two. Management only you have to understand कि you have to assess first and you have to treat later. How do you assess? You assess first, rule out any organic material. Don't think that something is OCD, that means it is psychiatric. You might have nutritional deficiency which leads to the repetitive eating behavior in a particular. Rule out vitamin deficiency, anemia and things like that. Rule out the thyroid disorders which are associated with the neuropsychiatric manifestations. Rule out the other infections and the pandas and other things that we just spoke about. Then you start assessing on the scores. We give a score for every behavior, how many hours they spend per day, okay? And that's how we assess. So we have scale called as a Yale-Brown Obsessive Compulsive Scale and Yale Global Tic Severity Scale. So you just remember, how do you assess? You assess on the Y box. We call this as a Y box. And if you know Y box in OCD, and that is excellent in third year MBBS or second year MBBS. Read Y box after going back. It has a very numerous items, very interesting. Read what is magical thinking. And treatment is very simple. SSRI first line treatment. What is first line treatment? जोर से. SSRI is the first line treatment. What are SSRI? Excellent. Can you give examples of SSRI? Very good. Fluoxetine, fluoxamine, escitalopram, sertraline, paroxetine, these are the SSRI. Go back and read their doses, right? We will ask this in the next this thing. Then clomipramine is a tricyclic antidepressant, the only tricyclic promoted for the obsessive compulsive disorder. Add-on or augmentation agents are risperidone and aripiprazole in very low doses, not in antipsychotic dosages. They are antipsychotic given for psychosis, but here they are given as an augmenting agent, not in antipsychotic dosage, lower dosage. Ondansetron helps. Benzodiazepine to relieve anxiety associated with, and venlafaxine is a SNRI, right? So it is one of the agents promoted. Then the somatic treatment includes RTMS, repetitive transcranial magnetic stimulation. It is still in the infancy. It can treat resistant OCD symptoms. That's the claim. The evidence is yet established. We have few cases. I have seen few cases which required psychosurgery. When I was in Nemans, gamma knife is one of the thing, and then the latest thing which is a deep brain stimulation. Read about it, it's very interesting. Very resistant cases of OCD are treated with the deep brain stimulation. It's not available at our center as of now. Psychological treatment is ERP, CBT, and the madam will talk about it. Okay, so what is an obsession, madam? What is an obsession? We have to know at the end of the lecture whether we got something or not. Stand up. If there is enough room to stand up. Yeah. Okay, which are anxiety provoking or distressing or impairing the functioning of a person. Sit down. What is compulsion? Sit down. So some repetitive action to relieve the anxiety. Enumerate some theories of OCD. Yes, madam. So many. Sit down. Sit down. ठीक है. So psychoanalytic theory, behavior theory. Psychoanalytic theory you can talk about the Sigmund Freud. The behavior theory you can talk about the Maurer two-stage theory. And attention theory we just spoke about, attention, bias, error, signal detection. So neurophysiological and neurobiological theory, cortico-striato-thalamo-cortical circuit. Differentiating from other similar symptoms like anxiety, depression, we just saw that. Treatment we saw, which is the treatment? SSRI. ठीक है. Madam will take from here onwards 10 minutes for psychological therapy. You have the
pen drive. I mailed it.
You mailed it, but I have just read it. I have not copied it to you because it had different format.
Oh.
It was going beyond this.
So
You
I'll have to copy.
you have it. Good.
Can I use it?
You have the laptop. Or you can present from the laptop also, not a problem. Directly from the laptop.
I don't know how to attach it.
No, directly from your laptop you can keep it there and then attach.
Okay, so
मेरे लैपटॉप में भी है अगर आपको चाहिए.
okay, so
Hmm? मैंने सेव कर रखा है इसमें. You can meanwhile start. You can start. I will give you. Go. Go.